All right. Good day, everyone. Um, I'm Aaron Moralina, a PhD candidate at University of Hawaii at Manoa. And my presentation for today is entitled Why the Philippines Never Had Socialized Medicine. I'd like to start with um, a sense of the biopolitical landscape of the 1930s Philippines. The Philippine Commonwealth government was the closest that the Philippines could have gotten to a welfare state. The country possessed all elements of socialized medicine system. The number of beds, hospital beds, and the number of its active Filipino doctors were comparable to that of the United States. Filipino medical luminaries were comparing the Philippines' healthcare capacity with that of the United States, and were in agreement that Filipino doctors were as good as or even better than US doctors. The country also had a strong activist government whose constitution made a commitment to science and biomedicine. Um, the Philippine Commonwealth government deviated from the earlier insular government's medical carceralist approach and had promoted the hospital as crucial to nation building. In 1939, Manuel Quezon declared that the National Hospital Day, and I quote, serves as another milestone in the steady progress being made in safeguarding the life and health of every Philippine community. Um, the government has built additional hospitals, sanatoria, and maternity homes. It has established free clinics and periculture centers in towns, and is now providing remote communities with adequate public dispensaries, end quote. Before the word socialized medicine gained a negative connotation due to the Red Scare of the Cold War period, socialized medicine was mentioned by Filipino lawmakers as a possible model to adopt locally. In 1940, Antonio Villarama from Bulacan, chair of the Health Committee of the National Assembly, upon his return from his 1939 US tour, declared with almost certainty that socialized medicine is coming in one form or another. Even the most critical about it feels that way. The American Medical Association has taken a compromise attitude by advocating some national agency, or properly speaking, federal entity to take over health activity, a Department of Health. After the Japanese occupation, when Villarama became uh, the health secretary, there was no shortage of advocates of Britain's NHS. So the country seemed to be poised to head toward the adoption of a universal healthcare system with government medical services on the march and politicians adept at the language of social rights. What happened? So to find out the answer, let's go back a few years earlier. Earlier, I said that the government medical services was on the march. This was a long time coming, and policies dating back to 1910s and even earlier. But medical government medical services took off in the midst of the insular public health's expansion outside Manila in the 1920s. Filipino medical licentiates were joining the Servicio Sanidad de Filipinas, in English, the Philippine Health Service, in scores as field health officers and as provincial public hospital physicians. Positions which became lucrative career options during the time. This was made possible through various insular level investments in the construction of provincial hospitals and an increase in the role of provincial hospitals in organizing and financing their own local health organizations. In 1932, disgruntled private doctors who were members of the Philippine Islands Medical Association, the precursor of today's PMA, formed the Philippine Federation of Private Medical Practitioners, PFPMP. The formation of the PFPMP was the opening salvo of organized restiveness that had been percolating among private doctors amid the Servicio Sanidad's expansion in the provinces. In the years heading to the PFPMP's formation, a crescendo of accusations was coming from the provinces that the government was taking away paying patients from private doctors. The government doctors denied these accusations, but they were not without basis. On paper, field health officers were meant to cooperate with private doctors, and provincial public hospitals had to accommodate them by renting out their facilities. But all of these created on the ground a sense of a loss of cultural authority and economic autonomy to private doctors, previously the sole practitioner of biomedicine in their hometowns. Private doctors had to deal with outside forces, field health officers who suddenly were mandated by insular law to go from one town to another and visit people's houses, and provincial hospitals that were offering free medical service and accurate laboratory diagnosis. So, unsurprisingly, reports aplenty about patients seeking government medical services, even well-to-do ones, and leaving their private doctors. In 1934, the PFPMP graced the English language Manila Press when a string of controversies hounded the Philippine General Hospital, or the PGH. The most explosive controversy took place in June of 1934, the food poisoning case involving a family who was delayed admission to the hospital, resulting in the deaths of 5 of its members. Calls to take PGH to account were swift. The PGH dismissed the ambulance surgeon, a junior resident physician, on grounds that he failed to recognize the seriousness of the family's medical condition. The PGH also received Malacanang's endorsement. But public outrage targeting the PGH top officials ensued. The PFPMP went to the rescue of the ambulance surgeon, lashed out at PGH officials for scapegoating the young doctor, and joined calls for an independent investigation. Malacanang convened a committee. The investigation's findings, whose records are found at the Joseph Ralston Hayden papers in Bentley Library, University of Michigan, challenged the long-held impression that Philippine state institutions were superior in every aspect. In the years heading to 1934, bias in favor of state institutions caught on among health policy circles in American Malacanang, in Filipino legislature, and even in the provincial governments. A general trend in policymaking promoted the thinking that health and welfare matters were most efficient and most economical under state management. All aspects of public health, preventive and curative medicine, control of epidemic and endemic diseases, social hygiene, maternal hygiene, etc., that used to be managed by non-government groups had to be taken over by government institutions. For instance, in 1932, Malacanang led the almost swift transfer of puericulture centers from NGOs to the local government responsibility. For the longest time, puericulture centers, small clinics that combined medical treatment and social welfare service, were managed by women's clubs. The move to put them under direct government management found rational in statist medicine philosophy. Government management was better because of superior, quote unquote, State capacities, the ability to take the bird's eye view, access to state coffers, the capacity to mobilize necessary labor power, and overall better medical expertise. Puericulture centers managed by women's clubs made limited impact due to the fact that their operation was restricted to the city centers and cacique families' hometowns. Once they were transferred to government management, periculture centers would have made greater impact. Health officers and public health nurses and even sanitary inspectors were able to see where they were actually needed, areas with high infant mortality even beyond city centers. State bias was especially strong in the case of the country's premier state hospital, the Philippine General Hospital, PGH. PGH's medical service was long viewed as the best in the country. Its medical staff was viewed as the best ever. This reputation was in great part due to the hospital's close connection with the University of the Philippines School of Medicine and Surgery and School of Nursing, long deemed as the best in the country. To be sure, these institutions were built as American civilizing biopolitical centers, which explained their substantial insular government resources. But their reputation continued as Filipino led institutions. PGH and UP had access to the largest medical library in the Far East. They had access to Manila Bureau of Sciences laboratory facility, and also Manila's city morgue. So naturally, PGH hospital treatment had to be superior in every way. But all of these impressions unraveled in 1934. It turned out the PGH could not accommodate their parent patients well. Their medical staff was receiving patient complaints every day. The hospital halls were constantly overcrowded with people waiting for charity ward opening. Even the junior medical staff and nurses complained about being overworked and underpaid. On the one hand, the PGH pinned all of its problems on the inadequacy of its state subsidy. As the PGH director, Fernando Calderon, declared, and I quote, all of our problems will be solved once the insular government gave us bigger funding, end quote. Bigger funding meant more beds for patients and more likely that the deaths of the family were avoided with hospital admission and timely treatment. On the other hand, there was an impression that the PGH's problems um, were inherent among state institutions. The lack of accountability to their patients stemmed from the fact that their operational funding were not paid for by their patients and instead came in the form of government appropriation. Even the PGH doctors admitted this. Their service would seem impersonal and mechanical compared to private doctors uh, because they had little incentive to take human interest in their patients.